Good morning and welcome to today's ISEH Sports Cardiorespiratory Medicine Conference. We're delighted that this is the second year we're running this event, and we're also delighted to welcome so many international delegates. So thank you for joining us in whichever time zone you are in. Today's events are broken into two halves. This morning we'll be looking at respiratory medicine, and in this afternoon we'll be looking at sports cardiology. Today's session is going to be chaired by Professor James Hull and Julie Moore, and we're going to be first focusing on optimizing respiratory health and protecting athletes from respiratory illness. We're particularly delighted to be welcoming Professor Martin Schwellnus, who chaired the recent IOC guidelines on athlete respiratory health, followed by his South African colleague Wayne Derman on looking at how we maximize and protect respiratory health in athletes across international time zones. We'll then be looking at novel treatments for enhancing breathing performance by Professor Nick Tiller and deciding what's fact, what's fiction, and what is a fad. After the break, we'll be then going straight into looking at the breathless athlete with Dr. Clem. Importantly, the psychological component of athletic breathing, what do we know, with Professor Olin, and then the piece de resistance with our own Julie Moore, looking at detecting and monitoring breathing patterns in athletes. What are the best tools available to us? After lunch, we then move into our sports cardiology section, looking at investigations, management, recommendations to competitive athletes with arrhythmias and abnormal images, chaired by our ISEH sports cardiologist, Dr. Gatti and Dr. Sheikh. As you can see from the list of speakers, we really do have an exemplary cohort of international experts. Professor Sanjay Sharma looking at arrhythmias, Professor Lambert looking at ICDs, Dr. Gatti looking at valvular disease, Nabil Sheikh looking at myocarditis, and Dr. Flavio looking at coronary artery disease. I think it wouldn't be an exaggeration to say that collectively, this cohort of sports cardiologists have probably managed in excess of 100, maybe 150,000 athletes over the past 2 decades. So we really are very fortunate to pull these individuals together. Thank you all. But why is cardiorespiratory medicine important to ISEH? Well, our ambition is to be a world-leading institute for sport and exercise medicine. But of course, sport and exercise medicine isn't just MSK and orthopedic issues. We want to provide excellence in the diagnosis, prognosis, and treatment for all sports injuries and illnesses. And sports cardiology, sports respiratory forms one important component of how we manage the total health of our athletes. When we look at international competition, we always focus, there's been a significant amount of focus on heat, and we've seen that from Barcelona up until the recent Tokyo Olympic Games, the environmental conditions that athletes compete in are challenging from a temperature perspective, and we've seen that at the recent Tokyo Games being one of the hottest Olympic Games in history. But we've also seen that actually challenging environmental conditions are not just for the Olympics. So these are some of our cardiologists here, and you can see our sports cardiologist, Professor Guido Pielez, helping out at the recent Doha 2019 Games. And you can see here that actually 3 of the events were in the, it says red here, but within the black temperature zone. But temperature isn't just one challenging environmental condition. I was fortunate to work at a facility in the Middle East in Qatar called Aspetar, and this is a dusty day in the winter. And we know that challenging environmental conditions aren't just linked to temperature, but it's also linked to particulate matter. And we can see here now that actually with the recent World Cup due to be held in the winter, the temperature may not necessarily be an issue, but the environmental conditions where an athlete breathes may be in November, December. So again, what can we do to protect these athletes in these environments? When we move across to cardiology, I think we pretty much accept now that most sporting federations have a sports cardiology policy. Either it's mandated for some motorsports or it's recommended for other elite competitions such as rugby and football and hockey and other Olympic sports. We've been working with a number of providers to try and support them during the COVID pandemic about not having athletes travel to ISEH, but whether ISEH can travel to them. But despite a significant increase in the education that we provide to physicians on how to interpret ECG and reduce the number of false positives, how we are better in identifying subtle disease and risk stratifying individuals who may have an inherited or congenital cardiac condition, we still have a lot of work to do. All of these individuals on this page have been cardiac screened, but have suffered a major adverse cardiac event. It is not a perfect science, and this afternoon's program really is timely, considering the number of individuals who may have an ICD fitted and wish to participate in elite sport. We do know the trigger for sudden cardiac death remains elusive. We do think it's due to an unstable electrical physiological substrate, but again, the conditions that an athlete places themselves in, whether it's through dehydration, hot environments, prolonged exposure to large amounts of endurance and high intensity exercise, why is it one individual has a cardiac arrest and another individual does not? It's not a perfect science. This is data that we present that we have from my previous organization, Aspetar Orthopedic Sports Medicine Program, and we screened over 8,000 individuals. It's important to say that screening is not just a one-off event. Yes, we can identify the vast majority of individuals at first presentation, but you can see here that almost 35%, almost 40% of individuals were identified at a second screening. And we'll talk about that a little bit later on. So our cardiorespiratory medicine philosophy at ISEH is, how do we optimize health? How do we protect health? And if we do find something, how do we treat it? Whether that's through dissemination of recommendations about how we support individuals suffering a COVID infection, how do we disseminate that information to international media? And how do we produce consensus guideline statements to support the international community? So I hope you enjoyed today. I'm very much looking forward to it. There is a chat button in your link. If you do have any questions for the speakers, the chairs will help facilitate those questions, and we'll have an engaging Q&A session. I would ask though that if the speakers do present data that isn't published yet, there'll be a Twitter cross. Please do not tweet those data, but otherwise, I thoroughly encourage you to try and tweet as much information as you possibly can. So with that, I'd like to hand over to Professor James Hull, who will introduce the first session. Thank you.
Well, massive thanks, Matt, and I echo a warm welcome to you all for today's conference. I'm going to actually make some more comments regarding the introduction and a welcome in my talk that follows shortly, but just three housekeeping comments really. First of all, to say please send us lots of Q&A in the Slido system. We'll be looking at that, and there is a live Q&A session with the speakers that you'll see on the program. And so for the morning speakers, that's at 10:40. After the break, I'm going to hand over to Julie Moore, who will chair the subsequent morning speaker sessions. And again, there is a live Q&A for those sessions that immediately follows and just before the lunch break. Important to try and share the messages that we learned today. And so, as Matt said, please share on social media. The hashtag for the conference is hashtag ISEHSCRC. And so pop that into the social media feeds to share some of the important messages which I hope will arise from the talks. Listen, I'm going to just start the talk now because I do make some further introductory comments in that talk, and then I look forward to getting started. So big welcome to everybody. Thank you.
Hi, so massive welcome to this year's Sports Cardio-Respiratory Medicine Conference. And I really want to just echo the introduction from Matt Wilson there in saying how much I'm looking forward to today's and this year's program. Fantastic schedule of speakers. And what I want to do is just start by setting the scene and providing some perspective on where I think we are with respiratory health in athletes and what are some of the key and important issues. For those of you who don't know me, I work predominantly as a respiratory physician at the Royal Brompton Hospital in London, but I also run a sports respiratory service at the Institute in London. And I spend a lot of my time advising the English Institute of Sport as their respiratory physician lead. I also just want to highlight that I've been involved, as many of my co-speakers on this program have been, in the IOC Task Force on Respiratory Illness in Athletes, which is due to come out a little bit later this summer. And I've also chaired the British Thoracic Society guideline, which recently came out on athlete respiratory health. Again, I'll share a link to that, but hopefully will provide some insight and some useful information for those interested in this area. So what do I want to talk about in this first 15 minutes? I want us to just start by taking time to pause and to think about where we're at with the respiratory health of athletes and how it's been impacted by the type of environment that we ask athletes to exercise in and what we could do to make this better for them. I want to highlight what I think are some of the big issues, particularly in the clinical context of looking after athletes. And then finally, I want to set the scene for the speakers to say, what are we doing? Why are we not learning as a unit about respiratory health? Still, it's the case that many people referred to me having waited for a diagnosis for many years. They've often been incorrectly diagnosed, and they're still struggling with troublesome symptoms, which are having a huge impact, not only on their enjoyment of sport, but their ability to progress and actually become the best athlete that they'd like to. So we're going to focus on all of these issues, and I hope as we move through the morning, we'll gain more intelligence about how we can do better as a community looking after respiratory issues. And of course, while we have this talk and a series of talks this morning, right across the globe, there'll be athletes training, preparing, competing in inhospitable environments, noxious pollutants around them, chemicals that they have to inhale, very cold and dry air, which we know are a direct insult to the airway lining. And of course, in order to travel and compete, potentially being crowded into places where they're exposed to infection, not least, of course, the big challenge of dealing with COVID. I always start with this slide, which tries to conceptualize how common and important respiratory symptoms are in athletes. This was a questionnaire survey a number of years ago now, which asked athletic individuals, how often is it that you report or notice difficult breathing problems or respiratory related issues? And you can see how common it is for athletes to have breathlessness or wheeze or cough, very common symptoms. And in fact, of course, as many of you will know, the incidence or prevalence of asthma, exercise-induced bronchoconstriction, or more commonly termed lower airway dysfunction these days, is very high, particularly in endurance athletes. Whenever we go and see a squad of endurance athletes, it's usually 1 in 4 of those individuals will have some sort of asthma-related issue. The most common chronic medical condition that a sports and exercise clinician will come up against when trying to help with an athlete. If we look at people undertaking sporting events, we see a high prevalence of respiratory tract infectious type symptoms. Here's a study showing this very nicely in individuals after they've competed in the London Marathon. And you can see even after 10 days of competing, the high prevalence of upper respiratory tract discomfort and symptoms of an infection in the upper respiratory tract, much higher than a comparator group who didn't undertake marathon running. In fact, if we look right across world-class sporting events, Olympic Games, World Championships, swimming events, youth and adult events, what we see consistently is this message that illness is very high in terms of the prevalence and its impact on individuals going to these major events. It's one of the key reasons that athletes at sporting events will seek out the medical tent and try and get medical input. But don't worry. I hear you thinking, crumbs, symptomatic, high prevalences of asthma, lots of issues with infection. Surely this is a disaster for people to be doing sport. But this is balanced very nicely by this huge movement and fads of different ways of using techniques to get rid of cleaning the lungs, different ways of inhaling canned oxygen, and these modern day ways and ways in which commercial ventures can actually help us with the athletes. I hope you notice, even though it's virtually, this is a sort of tongue-in-cheek message, and we're going to hear very much about the fads and the ways we need to steer clear of some of these different types of devices or ways of augmenting respiratory health, unless there's good scientific background behind them. Fortunately, we have the International Olympic Committee, and of course, one of the key drives of the medical code within the IOC to do everything we can to protect and safeguard the health of athletes to make sure they don't suffer physical or psychological harm. And as I said at the start of this talk, I've been very pleased to be involved in an expert panel chaired here by Mathew Schwellnus, who you'll hear speak shortly, where we gathered in Lausanne last year, actually, and have created a number of documents or expert consensus statements in order to try and help provide people interested in looking after and the care of athletes with the best guidance in terms of optimizing respiratory health. So there you have it. This is the first part of the morning session to follow. We've got Martin Schwellnus talking about some of the new recommendations from the ISEH guidelines. We've got Wayne Derman here. Actually does come from South Africa, but I couldn't fit two of these huge ego and famous professors onto the same part of South Africa, so he doesn't come from South America. He's going to talk about air travel, what it does during international travel in terms of the risk of infection, and he gives a fantastic talk in this area. And Associate Professor Nick Tiller from UCLA, who's going to talk about fads, fiction, and different facts and ways in which you can interrogate some of the things you might have read about or heard about in social media and certainly pop up on my Instagram feed every day, encouraging me to try and help use these different types of devices, certainly in helping athletes. What about the clinical arena? Now, I've shown you these slides before, probably if you attended last year. You can see when I break down the type of athletic individuals who are referred to our service at the ISEH, what I tend to find is that a majority of individuals are referred with what you might term asthma-type symptoms. So they're developing wheeze, they're developing breathlessness, cough, and they're struggling with exercise. It will be the type of problem that for the majority of you will see as the most common type of issue, but of course there are issues with recurrent infections. And some individuals I see report underperformance or chest pain related issues. This is a typical case. This is actually a video very kindly shared from Todd Olin, who you'll hear speak in a short while. But here's a young athlete struggling with breathlessness, wheeze, and troublesome symptoms. Some of you will be watching that thinking that's either yourself when you try to exercise, or actually certainly some of the members of a squad that you might look after that you just assumed it was either them and the way they breathe, or them and it's their asthma that's causing those types of symptoms. And this isn't a phenomenon which is unique either to Scandinavia or to North America. Here's some data from Ollie Price, who's in Leeds, and his group, looking at the prevalence of breathing-related issues and audible breathing sounds in the context of a park run. For those of you who don't know, this is the park run starting here. This is in the summer in Leeds. And you can see athletes heading off, and they're going to try and run as fast as they can around a 5-kilometer course. And Ollie and his team made some sound recordings as these individuals ran into the very end of the event and asked them about their symptoms and also recorded the sound. And what you found was that 1 in 10 of the individuals that were recorded had some form of an audible sign of respiratory distress in some way, and also reported some respiratory symptoms. So this wasn't just a benign finding, this was something that was causing them some irritation. What was intriguing and very interesting from this analysis was that actually there was quite a high prevalence here, as you see, of these individuals reporting a wheezing type sound that was predominantly on the in phase of breathing. So involving the extrathoracic airway, the upper part of the airway in so-called stridor. What about the others? What about generally with respiratory symptoms? When you see athletic individuals, some people say, well, they report breathing problems at a very high prevalence because they're more attuned to their body. They're more psychologically in tune. And of course, for many of them, the psychological stress of performing is actually causing their symptoms and exacerbating it. Here's some data from Oxford looking at how athletes report the intensity and the anxiety associated with breathing symptoms during an exercise test. And actually, you can see that, okay, there might be a slight increase in anxiety during maximum exercise, but by and large, the type and the way that athletes perceive their breathing in the context of an exercise challenge is roughly the same to sedentary control subjects. So there's more to it than this. Within the British Thoracic Society statement, which I recently chaired, we talk a bit about how you interrogate or pull apart the different type of symptoms that athletic people might get when they're reporting breathlessness and cough and wheeze and other symptoms. There are a number of what we call red flags that you need to identify. So thinking about if there's coughing up with blood or weird sharp chest pains or syncope and palpitations, there are important conditions to consider. But by and large, the majority of diagnoses are explained by one of three conditions: either some form of asthma-related issue, a condition called ILO or exercise-induced laryngeal obstruction. You're going to hear a lot more about that in the subsequent talk, some of the subsequent talks this morning. And this other disorder, which is still very overlooked, but very important, certainly in the patients and athletes that refer to me, BPD or breathing pattern disorder. These clinical conditions have different clinical characteristics, such that you'll hear, I'm sure, that some individuals report their symptoms at peak exercise and that the symptoms rapidly abate on exercise cessation. Some find that actually their symptoms can be a bit worse when they stop exercising and actually take quite a bit of time to resolve, and others where the symptoms are completely and utterly chaotic and don't seem to have any sort of relationship, such that you can be a very highly trained athlete but then become very breathless simply walking up a flight of stairs. Some individuals report symptoms that localize into the throat, others to the upper chest, others where there may be more diffuse symptoms and they may be associated with symptoms like dizziness. And we can start to interrogate, pick apart the types of symptoms to work out whether they might be more likely to be related to ILO, exercise-induced bronchoconstriction, or this disorder BPD, shortened for breathing pattern disorder. And again, I don't want to steal the thunder of the subsequent speakers, but they will talk a lot about some of these important conditions, and I hope highlight some of the key things that will help you pragmatically. Certainly ILO is of great interest to me. It's a very interesting condition because it appears to be very closely linked to exercise intensity, as shown by Todd Ollin's work here. And it is always described when I see athletes as go time as to when it occurs. So if you're a professional cyclist, it's when the brake is going down the road or you're suddenly having to put the hammer down on a climb. And if you're based in a field-based sport like hockey, then you will see it when you get your squad to start doing the shuttle run to see how fit they are at the end of the shuttles. This really is a very closely linked to intensity. Hege Clem's going to talk about ILO. She's offshore going to talk about the diagnostics that we need. But what I'd like to put to her and for her to think about certainly is why it is that from a time where we really understood and learned about this condition in 2006, that we're on now, almost 15 years later, and yet studies have shown that the prevalence of this condition might be as high as 5% of the adolescent population. And yet within the UK, we still have very poor generalized perception of this condition. And it's still the case that people wait many, many years to get a formal diagnosis whilst they're incorrectly taking asthma treatment. We're not doing enough, and we're not getting the message out to the right type of people so that people can be treated quicker at a time when they're developing in their sporting career and a time when it might be crucial for them to actually progress to the next stages in their professional ambitions or aspirations as an athlete. So the second half of the morning is going to be some fantastic talks. I've introduced the speakers, Hege Clem and Todd Ollin, some of their work and their background. And Julie Moore is our lead respiratory physiotherapist who has a world-class reputation in this area now. She's going to talk about the third entity that I raised, BPD, and talk about some of the measurement tools. So on that note, I'm going to stop. I'm really looking forward to the Q&A session at the end of the morning. I'm very grateful to some of the speakers who are joining at very inhospitable hours. I did say I would highlight some further sources of information, and certainly our British Thoracic Clinical Statement can be downloaded and accessed for free via the British Thoracic Society website. So I encourage you to have a look at that, and hopefully that will signpost to many of the speakers' work as they speak today. I will stop there. Thank you.
Great. So we're going to move on now, and it's my great pleasure to welcome Professor Martin Schwellnus to provide the next talk. Martin is the director of the Sport, Exercise, Medicine and Lifestyle, or SEMLI Institute at the University of Pretoria in South Africa. He's heavily involved in the International Olympic Committee and leads the research centre in South Africa, certainly over the last decade. Also acclaimed and a fellow of many different organisations, including the ACSM. Martin has also, as I said at the start, been leading the new guidance that's going to appear, I think, in August of this year from the IOC with respect to respiratory health. And so I've asked him very kindly to provide some highlights or top line messages from some of the work that's been going on, and I hope that'll be of great interest to you. Thank you, Martin.
Good day. My name is Professor Martin Schwellnus, and I would sincerely like to thank the organizers of the ISEH for the opportunity to discuss the new IOC guidelines on acute respiratory illness in athletes with you. The title of the presentation is the IOC guideline on athlete respiratory health, and the question we're asking is what is new in these guidelines? As an introduction, it's clear to all of us who've been in the field and working for a long time that the prevention and management of acute illness is a very important component of the work of a sport and exercise medicine team physician or clinician. We also know that about 50% of all medical consultations at sports events are as a result of acute illness in athletes. We also know that the respiratory system is very consistently the most common organ system affected. It is for this reason that the IOC decided to convene a special group to look at a consensus on acute respiratory illness, realizing that there are multiple causes which can be broadly classified as acute respiratory infections, or the so-called part 1 of this consensus, and non-infective illness. A core group was established in mid-2019, started work in about July, and completed its work in April this year. The core group depicted on this picture consists of 22 members, and there were 7 subgroups with an additional 35 members that were working independently as well. The final consensus statement was held in a meeting in Lausanne in October last year, and the manuscripts have been completed. The main aim, as I've indicated before, was to provide the sport and exercise medicine physician or clinician with an overview and a very practical clinical approach to acute respiratory illness in athletes. The 2 phases of the work over about 2.5 years was a preparatory phase consisting of lots of work from all 7 subgroups. And these groups conducted systematic reviews, some with and others without meta-analyses, or narrative reviews of the key areas. And the final phase, or phase 2, was to incorporate these main findings into the statements that I will discuss briefly. For those of you who are interested, this is a list of the current outputs that were published by various subgroups, which form part of the core content of the consensus statements. And you're welcome to access these in various journals online. So what is new? And I'm going to divide this into the 2 parts to the consensus that have been completed. The first one being the acute respiratory infections, or AR-INF in athletes. And I will extract 5 main points that were new, certainly for me, and maybe for some of you as well. Of course, this is a very comprehensive document and is impossible to discuss in 10 or 20 minutes. So these will just be my 5 main points, and I think they may be of value to you. In the second part of this lecture, I will focus on part 2. So let's move on to these 5 main points. I think the first point, maybe not so new, but very consistent, is the incidence of acute respiratory infections in athletes during tournament. And this is best looked at by consulting the systematic review that was published recently in BJSM. Essentially, the main finding is that acute respiratory infections, mostly suspected infections by clinical diagnosis, as an incidence of 1 infection per 200 athlete days, which could easily be translated into a tournament. For example, where there are 200 athletes participating, there will be an infection every day. This slide does show 1 column, the bottom one, which is a little higher. And this is in a very small number of studies where the viral pathogens have been identified. In other words, this is a confirmed infection where there's an apparent increased incidence. And this is a new finding as well. The second new point is that for the first time, this group actually classified the various clinical syndromes of infections in athletes. These syndromes were predominantly upper respiratory, and this is important because this accounts for over 90% of all infections in athletes, respiratory infections in athletes, or predominantly lower respiratory tract infections, which are quite rare. The two highlighted in red are two subclassifications of the upper respiratory tract, and these are by far the most common cause of acute respiratory infections. Previously known as the common cold, which is acute rhinitis with either or additional features of rhinosinusitis or rhinopharyngitis, and the influenza-like syndrome, which is the similar clinical picture but with systemic symptoms and signs. The third point that is fairly new but familiar to all of us is particularly highlighted by the SARS-CoV-2 pandemic. And this is to consider the possibility that there is multi-organ involvement, which could result in complications that are part and parcel of an acute respiratory infection. And the consensus group summarized this potential list of complications in various organ systems with some examples of pathogens. So this is an important part of return to sport decision-making, which I will briefly highlight a little later. A fourth novel contribution from this group in this area is to propose a classification for the severity of infections in athletes. And a number of clinical considerations were identified to assess the severity. And these include the time course of the disease, how long it is, symptoms, probably the most important factor in determining severity by type, location, severity, and how long symptoms last, clinical features on examination, and then special investigations. This is a complex and very comprehensive table that I'm not going to discuss for lack of time, but this is the table that is published in that paper, which gives the clinician the criteria, both based on symptoms or clinical signs or laboratory investigations, to classify athletes with acute respiratory infection into a mild, moderate, or more severe complicated infection. And this is again important in the determination of return to sport. Finally, in terms of the part one, is a fairly comprehensive return to sport decision-making process, which has been put together by the group. A few general points on return to sports, sometimes not well understood, is that the return to sport is a process and not a single decision. And there are probably two key decisions. The first decision is when, after an infection, can an athlete return to training, with a second decision when the athlete is in training, when can the athlete return to full exercise or sports performance or competitive performance. And it's only when the final full return to sports performance decision has been made, the athlete is considered to be fully returning to sport. The second general point is that the group considered the so-called START framework, which is well known, in a stepwise decision-making process. This START framework was modified to some extent by the group by including a first point in the step, or first step, which is to assess the severity of the infection based on symptoms using the table that I've described before. The other three steps, which is determining the health risk, determining activity risk, and in considering the risk tolerance, follow the START framework. Highlighted in red on this slide is a novel contribution from the group, and that is to include a pre-exercise checklist and also a post-exercise checklist, which can be used as an ongoing checklist until full return to sport. This is summarized again in this rather complex flow diagram, which will be in the paper. But on the right-hand side are those four steps that I just outlined: assessing disease or infection severity, determining health risk using a pre-exercise checklist, determining the activity risk using a post-exercise checklist, and then considering other risk tolerance factors. Important contribution as well in this process of return to sport is a self-administered pre-exercise checklist, particularly for those athletes that were classified as either mild or perhaps even asymptomatic. And this is a first for return to sport decision-making following acute illness, particularly infections, as far as the group is aware of. This is just an example. I'm not going to go in detail of such a checklist. This is the pre-exercise checklist that can be self-administered by the athlete or the coach. I'd like to now move on to the second part, or part 2, which is the non-infective acute respiratory illness paper. And again, this is a very comprehensive document with a lot of detail. And I am only going to extract what I consider 5 main important or novel points, at least from my point of view. Probably other people will have different views on what is new and important. So these are my own personal opinions. The first, and I think very important consideration, which is probably well known but needed to be emphasized, is that in the respiratory tract, it is important to understand that there is an anatomical, pathological, and functional continuity between the upper and the lower airways. And the consensus group elected to discuss upper airway and lower airway pathology as predominantly affecting the upper or the lower airway, knowing that there is a continuity. So as far as causes for non-infective illness, which are discussed in quite a lot of detail in this document, those that predominantly affect the upper airways would be nasal obstruction, which could be structural or mucosal, and could include allergic and non-allergic rhinitis or rhinosinusitis, as well as pathology in the laryngeal area, specifically focusing on exercise-induced laryngeal obstruction, or ALO. Non-infective illness predominantly affecting the lower airways is classified as lower airway dysfunction, and I will come back to what that encompasses, and also recognizing some rarer conditions such as excessive dynamic airway collapse and tracheobronchomalacia. This is a summary of the anatomical and pathological classification of the non-infective acute respiratory illnesses that are discussed in this document in a very comprehensive manner. So one of the points that I learned out of this is not to forget the nose. And nasal conditions have not really been studied, reviewed, or considered well by most of the sport and exercise medicine clinicians. And one of the contributions from this group was to publish a narrative review on nasal obstruction, which is available, and also to include a diagnostic approach to the athlete presenting with symptoms and signs of nasal obstruction in the Part 2 document. The flow diagram is highlighted on the right-hand side. Essentially, it is important to consider that nasal obstruction can be structural and or mucosal. The structural causes can be static, such as post-traumatic, or dynamic, with involvement of collapse of the nasal valves during inspiration. And the mucosal causes are usually related to inflammation and swelling, and could either be allergic or non-allergic or infective. Also, a novel point to consider is the importance that not all non-allergic rhinitis has the same phenotype, pathophysiology, and therefore not the same treatment. And this diagram, which is published in the consensus, highlights that. And on the left-hand side are the various phenotypes of non-allergic rhinitis, the pathophysiological mechanisms, and the treatment. The third point in this Part 2 is to think about and distinguish ALO from EIB. And there are key differences in the clinical presentation, I'm sure will be highlighted in the symposium as well, between ALO and exercise-induced bronchoconstriction. And this is a summary of the main differences in the figure. The fourth main point is to realize that lower airway dysfunction, which in this consensus is defined as conditions such as asthma, EIB, and airway hyperresponsiveness being collectively included in the definition of lower airway dysfunction, and that this is very common. A systematic review was published in BJSM and highlights that 1 in 5 athletes will have lower airway dysfunction, with some differences between types of sport, recreational versus elite athletes, summer and winter athletes, and aquatic and non-aquatic disciplines. The prevalence, therefore, is around 20%, with some variation, which is highlighted in this slide. So this is a very common condition. So in summary, in this lecture, I tried to highlight 10 points, 5 from the acute respiratory infection part 1 statement and 5 from the part 2 statement. These are arguably the most comprehensive documents on acute respiratory illness in athletes. And I only was able to extract, because of time, the 10 points that I mentioned. I would encourage you to look at the BJSM in the next couple of weeks for the announcement that these are online, and encourage you to read these in much more detail. Thank you very much for your attention, and I'm happy to answer a few questions.
Martin, thank you for a fantastic talk. We are massively looking forward to those statements coming out. I should please just remind people, actually, those are yet to be published, a number of the points that Martin made there. So if those could not be widely shared, that would be appreciated. I know there wasn't a Twitter with a cross sign with a cross through it, but I think some of those pieces of information are not in the public domain or published yet. So thank you, and I look forward to chatting to Martin a little bit later this morning, and please put your questions in the Q&A. So we move on now to Professor Wayne Derman. International travel has been a big concern, and of course with the COVID pandemic, lots of different considerations. And so Wayne gives a fantastic talk in this area. He's the executive head of sports science and the head of the division for the Institute of Sport and Exercise Medicine at the beautiful University of Stellenbosch. He's helped lots of athletes, particularly serving on the International Paralympic Committee. I know some of the famous athletes he's helped include world-class chess players, for instance, and he has a keen interest on helping chess sports people. So, Wayne, massive thank you, and look forward to the Q&A after your talk. Thank you.
Well, a very good morning or good afternoon or good evening, wherever you are watching this and have logged into this conference. Greetings from a very wonderfully warm Cape Town, even though we are heading into winter. You see a lot of the sunlight and sunshine behind me. Thank you very, very much, Matt and Jim, for inviting me to speak at your conference. And particularly for allowing me such a great title of the talk, with something which is very close to my heart, which is how to protect the health and particularly the respiratory health of athletes during international travel. So travel is one of the times of risk for health issues or health problems when it comes to athletes. The slide you see before you is a study that we did looking at travel and illness during the Super Rugby competition, which is when teams from South Africa and Australia and New Zealand play each other. And we documented in about 250 elite rugby players from 8 teams their baseline illness before traveling, and then after they've traveled away from home, and that would be a long international travel of more than 5 hours time zone change. And then we measured their illnesses on return. And we found that when one leaves one's home environment and travels more than 5 time zones, there is a significant increase in the incidence of illness when one looks at illnesses measured per 1,000 player days, regardless of if you're traveling east or west. And that returns back down to baseline when you finish traveling. So this is all illnesses, but this is also specifically respiratory illnesses. And that shows the effects of traveling. If we have a look at some of the Paralympic data that we measured during the London Paralympic Games, this also shows the illness measured in illnesses per 1,000 athlete days. And this particular data set looks at respiratory illnesses. And you can see that if you're traveling from most other continents to the UK, the incidence of illness is much higher. And it really shows that home ground advantage quite substantially when it comes to illness and illness prevention. So therefore, I think I've made my case that when one looks at travel, this is a large risk factor for illness and especially respiratory illness. So the rest of my talk, I'm going to really focus on 4 areas. One, how does transmission of these illnesses occur? I'm going to present a model for illnesses in elite athletes while traveling that will help us understand how to prevent these. I'm going to speak about the unique features of the traveling environment, and finally present some practical advice for team physicians who are traveling with their teams and how to minimize the risk of these illnesses that I have been discussing. So if we look at the sports medicine literature, you won't find very much data on this topic. And one needs to actually go to the areas of medicine that fills that gap. And that is the body of medicine that exists out there with respect to travel medicine. And if one has a look at the travel medicine, starts answering some of the questions that we need to know. So the first is, what recognized spread of pathogens are there out there in the literature on travel medicine? And we turn to case and outbreak reports, and you'll see that this is quite a number of various different pathogens, not limited to only viral illness. So we see that when one looks at bacteria, there have been outbreaks and case histories of Mycobacterium, E. coli, and Shigella. Obviously, the viral pathogens, we've had so much in the last couple of years about COVID-19 and the effects of increased susceptibility and transmission during travel with respect to COVID-19. But there are other important viruses as well, for example, measles, Ebola, rubella, MERS, SARS, and other influenza type organisms. And then there are the fungal pathogens as well. And even the risk of picking up something fungal is increased during travel. So how are these diseases spread? And there are 5 ways during travel that these diseases are spread. The first, which is the best known way, is contact. And that means contact either from one person to another person, which is called direct contact, like you see people shaking hands. Then there is indirect or fomite contact. For example, the human interaction with that toilet would be an example of that. Then there is droplet-borne transmission of infectious disease. And I will speak about that in a little while. Together with droplet, we'll speak about airborne diseases. Then there are 2 others which are important, and that is common vehicle transmission. Common vehicle transmission really speaks to what you see in that small picture, which is the trays that are being prepared with the various different foods and other beverages. And if one picks up diseases from that, that's common vehicle spread. And then there's vector-borne. And the reason they spray the planes before travel really is to decrease the vectors and the organism spread from those vectors to the human being. So when it comes to the droplet and aerosol spread of diseases, we can see that this diagram depicts how the form of transmission actually occurs here from an individual, from an infected individual. Let's say that person sneezes or coughs. There are droplets. Those droplets can spread via direct contact to a susceptible individual. The droplets are more than 5 microns in diameter, and they travel particularly less than 1 meter. Those droplets can also fall onto person's hands, and then that person can actually touch their face, and that's also a form of direct contact. Or it can go to a fomite, for example, a tray table, and that can be an example of indirect contact when that is then transmitted to the susceptible individual. If that person who is sneezing or coughing produces very much smaller droplets, and the cutoff is less than 5 microns in diameter, those are aerosolized and travel typically more than a meter. They can travel substantially more than a meter. And that is an example then, if those particles are inhaled, an example of airborne transmission to the susceptible individual. So the different viruses form different size particles, and depending on the different sizes, they can either land close to other individuals or far from them. You can see that Ebola, being a larger type of droplet, can land up to 3 feet from an individual who's infected. And another smaller virus, smaller particles, for example, measles, can travel up to 30 feet or more from a particular individual. So moving to a model of illness prevention and illness susceptibility, and you'll notice that I spoke about the susceptible individual in the last slide. If one has a look at the traditional sports medicine model that has been made famous by Roald Barr and his colleagues and others, we know that this can hold true, and certainly does, for injury prevention, but we can also apply the same kind of model to illness prevention as well. So we then look at the concept of a predisposed athlete and a susceptible athlete. So if we take an athlete and we have a look at intrinsic risk factors and apply those, that could make the athlete predisposed to illness. If we take a predisposed athlete and then expose them to extrinsic risk factors, we then can have a susceptible athlete. Then there can be an inciting event. The event could be the travel itself. It could be exposure to various different individuals who are sick or have fomite contact. That then can precipitate an illness. So if we understand this model, we then know that there can be certain targets for mitigation with respect to intrinsic and extrinsic risk factors. So let's try and break these down. If we have a look at some intrinsic risk factors for the traveling athlete, we know that typically the traveling athlete can have poor sleep patterns. There can be the transient stress of either the impending competition period, or it can be the transient stress of the travel itself. And we know that various physiological stressors like time zone travel, high intensity training, or if we're dealing with patients with spinal cord injuries, those can be risk factors to cause a dysfunction of the immune system, further compromising the health of the athlete and leaving them susceptible. Then we can look at the extrinsic risk factors. Those extrinsic risk factors could be the pathogen exposure itself, for example, the bacterial, viral, or fungal. It can be the air quality, and we know that there are issues to do with recirculation, air humidity, and others that can occur on long duration travel. So let's explore some of that environment inside a plane in a little more detail. And you can see here in the slide in front of you that there are some risk factors that I have, for argument's sake, put in green, which can be modifiable, and those that perhaps are less modifiable in orange. So if one has a look at these, starting on the top left, top right, that can be the duration of the flight. We know that the longer the flight is, the higher the chance of illness. It can be the influence of the climate, the geography of where one is going to. We know that there are certain crew movements that are not controllable. How many times the crew comes down the aisles presenting various different options. All of those present opportunity for exposure. There's passenger movement and seating that is modifiable, and I'll speak a little bit more about that. Then there's the air that is very dry. There's barometric pressure and relative hypoxia. There's radiation. There is restricted space for one to move. There's whole flying environment is a very high contact environment with high contact rates between people and services. There are relatively a limited number of toilets for people to use, and that is something that we can't control. There is the circulation of the air, which again in some aircrafts is good and in some is bad, and we can't control that. Ventilation to a certain extent, we can control. Ineffective cleaning, we can to some extent affect that as well, and contamination of various different surfaces. Now, I would like to speak a little bit about contamination of surfaces. And this was a study done by the NSF Household Germ Study in 2011. And it revealed some very, very interesting findings when they looked at different colony-forming units of various different organisms. So let's start at the top right panel. And my mother always used to say to me, money is the most horrendously dirty objects, and one mustn't touch money or actually wash your hands after you've been touching money. Well, money in the greater scheme of things is actually quite clean. If one has a look at the number of colony-forming units per square inch and compare that with respect to cell phones, one's home toilet seats, again, one thinks that they are pretty bad. But just now we start getting to the real dirty things and look at one's home countertops in one's kitchen, our toys that our pets enjoy, and the pet bowls. Those are the really, really dirty things that are out there with 306,000 colony-forming units per square inch. Now, if we have a look at the panel below that, at what happens in an airport, if we touch an airport toilet block, that's 70 colony-forming units per square inch. Drinking fountains, 1,240, very dirty. We know which areas to avoid. And when we get to the left-hand panel and we look at where the dirty areas are inside the plane, if one has a look at the seat belt buckle, that is quite dirty. The overhead air vent, again, 285 colony-forming units per square inch. The flush button on the toilets is also pretty contaminated. But by far, the greatest area is the tray table with 2,155 colony-forming units per square inch. And then we also know from other studies that have been done, it is the seat backs, particularly of the aisle seats, that are important with respect to cleanliness. So there have been a number of studies that have used PCR to actually look at what different bacterial species there are. And luckily, most of these species are known opportunistic pathogens that we can deal with. It's when we start looking at being immune compromised that these really are important. 5 main genera have been associated with those studies, and that is Streptococcus, Staphylococcus, Corynebacteria, Katuria, and propionic bacteria. So when we now look at the interaction of these surfaces and how people move in a plane, we now start understanding this a little bit better. So there are these areas that are of high contamination, and we know that when people start touching these areas, they have a high number of colony-forming units that potentially are on their hands, and then if they move around, they then spread that. So if one has a look at the left column here, and looking at those 3 panels on the left, the aisle, the middle, and the window seats, you can see that if one looks at the number of contacts that people have, as the flights get longer, there are more contacts, which is understandable. But just have a look that the number of contacts in the aisle is significantly more than the middle seats, and both of those are significantly different to the window seats. So about 80% of people sitting in the aisle seat get up on their flights, and 62% of those in the middle seat walk around, but only 43% of people who sit in the window seat got up and move around. So the take-home message is that passengers who pick the window seat and stay there are least likely to be exposed to cold or flu viruses or any other viruses for that matter. I'm going to come back to the second panel in a different slide and speak about that. But I did want to share with you this also an important study that actually had a look, and I'm referring to that panel on the left-hand side of this slide, which shows the movement of crew through the plane. And these are those 2 squares marked in a blue L. Those are the lavatories or the toilets on the flights. And one can see that the people who move down the aisles, just look at the number of contact points that they have with the aisle headrest. And that is due to the fact that as the plane is moving, people touch those aisle headrests in an attempt to stabilize themselves as they walk to and from the lavatories. So we see that those are the areas that are very important with respect to avoiding touch in those particular areas. So what we want to do is we want to decrease exposure to organisms, and obviously bearing these patterns in mind, we can start suggesting certain mitigating factors, and we want to increase all factors that are going to enhance the immune system. Another interesting panel on this slide is shown at the bottom there, which really speaks to, if one looks at the far right-hand, the extreme right-hand corner, the different surfaces, and the more porous the surfaces are, the more there are areas for fomites to accumulate. And this speaks to new planes that are being designed now as to the materials that they're being made from have less ridges in them and therefore easier to clean. And this is something that we can look forward to as the knowledge in this field advances. The last thing I want to say about seating is the so-called rule of 2, which we now know through COVID times has been used to determine close contacts to an infected athlete. And that's why they want to know the athlete's seating plan for a particular flight. So there is a 6% risk of getting ill if you're going to sit in the 2 rows on either side of an infected individual. That's 2 rows to the front, 2 rows to the back, and along the side, right the way across that particular rows. And one can see in this particular slide here at the left, the right top quadrant, there is the index case in black, and you can see that the contaminated people who have had disease spread to them are sitting in those 2 rows. But it also shows that there are a number of people that are affected outside of those. And that really indicates the risk over and above the 2 rows. And that would indicate probably people moving around a plane touching fomites, for example. I think the last 2 years has shown us that face masks are particularly of value, particularly during flights. The case is now moot that that they have provided significant information that these work. One such study was this study here, which looks at the transmission of SARS-CoV-2 during a 2-hour domestic flight to Okinawa in Japan. And if one has a look at the middle of this table, it shows the number of cases, or have a look at the crude odds ratio or adjusted odds ratio when they adjust for wearing a face mask and maintaining distance from the index case. You can see that people who wear a mask all of the time have an odds ratio of 1. If you wear a mask most of the time, that doubles or nearly triples to 2.46 and a corrected odds ratio of 3. Then people who do not wear a mask at all, you can see a substantial increase in the risk of people. Again, you can see that in combination with that 2-row rule really makes an important case for distancing with, from an index person on a flight. Luckily, most of the modern day planes have HEPA filters, which really remove 99.5% of these smaller particles through the filtration system. It is really only the old planes or the older planes that still do not have these systems where this can be an issue. So in the last minute, what I would really like to do is provide some practical advice after all this has been said for the team physician. So the first thing is I would really advise having an educational briefing session for traveling athletes and the staff regarding a travel strategy, and actually show them some of these data that I've shared with you today of showing where things are not perhaps as clean as one would like, and that there are various different risks and that there are things that we can do about it. If it's at all possible that you've built up sufficient miles, or perhaps you're lucky enough to be with a wealthy club, then that business class upgrade it's a good time to do it when you're traveling. So that does decrease the risk. If you're going, can choose a seat, choose a window seat wherever possible, towards the very front or very back of the plane, and stay there as long as possible. Obviously, if you're staying for a long flight and are not moving around much, please do your leg exercises and wear good compression socks when you're going to take that risk. So that mitigates the risk of a DVT. Then when boarding, the plane touch as little as possible, especially the backrests of the aisle seats. And as you sit down, it's a good time to release your inner germaphobe and use your antimicrobial wipes or fluids containing more than 70% of alcohol. And then you target the most dirty areas, which are the seatbelt buckles, the overhead air vent, and your tray table. That's most important. Remember to use the 3-step process. Cover it with the fluid, wet it, and then let it dry. It then stands to reason that once you've cleaned your overhead air vent, then let that air vent push the air between you and the person sitting next to you. So you're going to make your own little laminar flow environment to actually stop any contamination coming over airborne to you. There's no data that actually shows that that works, but it, I suppose, pragmatic and prudent. Then if there's a sick passenger within your 2-row environment, inquire of the staff to either move you or insist that a mask is used. I think that in susceptible individuals, particularly athletes that travel poorly, and certainly now as the masks mandates around the world are dropped, I would still travel with a face mask on. And hopefully I've shown you enough data to say that if you feel vulnerable and don't travel well, then use a face mask. Use the correct methods for putting the mask on and off, and use a combination of hand washing, using the correct method, and hand sanitizer following each visit to the toilet. Use the antimicrobial wipes when touching the flush button, and also opening that toilet door on the way back to your seat. On the way back to your seat, avoid touching the aisle seat backs again. Then it's not respiratory, but mostly GIT illnesses to avoid, particularly insufficiently warmed food and beverages, which have not been boiled. This often is the coffee that they serve on a plane. If in doubt, leave it out. Don't drink water from the water fountains in the plane, even if they say it's potable. Maintain your hydration during your flight. Use your own pillow, if possible, and travel with a number of pillowcases to maintain hygiene. Then nasal hydration, again, very few studies have shown any significant effects, but it is an idea to use mupirocin or Bactroban intranasally just to maintain hydration of those mucosal membranes. And if you're going to use a blanket, make sure it's come from a sealed package. So it sounds like a very hectic type of strategy. But remember that if you're going to be traveling with people or athletes who we know are poor travelers, they get ill when they travel, then perhaps when we're looking for this marginal gains or that 0.5%, it might be valuable to let an athlete like that travel like this, or even members of the staff who travel poorly. So identify your athletes who have high intrinsic risk factors, and have a look at mitigating using prevention strategies against those risk factors, as well as the extrinsic risk factors. Do what one can to mitigate one's risk. One thing that the COVID pandemic has pushed us into a new era of sanitizing and prevention. And we now know that toilets in airplanes, and this is not even the future, it's already here in some modern aircrafts, now have ultraviolet lights, that as one leaves the toilet, the ultraviolet light sanitizes the entire inside. We can look forward to much more of these and other countermeasures in the future. So I apologize for going over my time a little bit. I apologize if my cat meowed a lot during this presentation. This is one of the joys of being able to present via online media. But thank you so much for your attention, and I hope you enjoy the rest of your conference. Bye-bye.
Wayne, thank you very much indeed for a fantastic talk. Lots of practical information there, which I'm sure people will find of great value. I'm flying tomorrow. I've just looked at my seats, and I'm in the middle of the plane and in the aisle. So I suspect I'll be falling ill a few days from now. So listen, we're going to move on now to Associate Professor Nick Tiller, who is kindly joining us from UCLA in the middle of the night. Many of you who have an interest in respiratory science and respiratory science in the context of athlete health, I'm sure in your Instagram feed or on your Twitter feed, you'll be sent constant barrage of different devices or other ways in which we can enhance breathing oxygen out of a can, using devices to try and increase the strength of the muscles in your neck, etc. Nick has done a huge amount really to try and dissect or find a way through some of the fads and facts and fictions. And I've been very interested in some of his columns, particularly in the Skeptical Inquirer magazine, but also some of his research output as well. So it's a great pleasure to have Nick join us and to try and untangle some of these really important issues so that we can help provide the best scientific evidence to athletic individuals who come and see us. So thanks very much, Nick.
Okay, well, hello everyone, and welcome to the session. My name is Dr. Nick Tiller. I'm a senior researcher in exercise physiology and respiratory medicine at Harvard UCLA Medical Center. I'd like to say a huge thank you to the ISEH for the invitation, particularly to Dr. James Hull. It's a pleasure to be joining you today. So as a preface to this session then, the global health and wellness industry is worth an estimated $4 trillion. And you can see the breakdown in some of the subdomains here. And unlike in the clinical world, which has something of an evidence threshold, there is no such evidence threshold in the commercial world. Now, I don't want to go into the drug approval process. This is an infographic from the FDA showing the various procedures that have to be accomplished before a new drug can go on sale. It's not a perfect system, but that's perhaps a lecture for another time. But the point I'm trying to make here is that there is some governance, there is some regulation on the sale of new drugs. When it comes to health and wellness products and services, there is little to no regulation. Now, as a result of that, products are widely sold on baseless claims and very unconvincing evidence for efficacy. Manufacturers can make whatever products they want, they can make whatever claims they like, and they don't have to provide any evidence to support those claims. So I've spent the last maybe decade and a half trying to bring the two worlds of scientific skepticism and health and wellness a little bit closer together, because there is this huge disparity between the ethos of the scientific method and critical thinking and scientific skepticism and the commercial world of health and fitness. Now, in recent years, the respiratory system has become a target of the modern commercial health and wellness industry. And I think that's very interesting. This has happened for a number of reasons. The most obvious one is, in the last couple of years, is COVID-19. And a lot of people, unfortunately, have used the fear and instability from COVID to line their pockets, to sell products and practices with little to no evidence for efficacy. So they're really cashing in on the fear and instability and people's insecurities about COVID to line their own pockets. But even before COVID, chronic respiratory disease was had the third greatest morbidity and mortality associated with it, with a huge economic burden. We have to consider that the pressing issue of climate change placed a lot of emphasis on respiratory health that was covered in the media. And I think it's also fair to say that respiratory physiology is a fairly poorly understood subject in terms of the understanding by the general public. It's a relatively complex subject to get your head around, and this means that it can be more easily misappropriated for commercial gain. So in this session, I'm going to be giving, this session is basically, it's based off a review article that is currently under review, that's entitled Science and Pseudoscience in Respiratory Physiology. And within that, we take a deep dive. It's a systematic review on a number of different commercial respiratory products and services. I'm going to just very briefly touch on a few of them today. I'm going to talk about nasal breathing, nasal dilators, inspiratory muscle trainers, pursed lips breathing and diaphragmatic breathing. We'll talk about oxygen supplements, and I'm going to try and frame all of these products and services in the context of the 3 Ps. That's the premise. So what is the premise for how this product should work? How plausible is it based on our current understanding of respiratory physiology? And the final P is the most important one, the published literature. So let's start then by talking about nasal breathing and nasal dilators. So there are a number of different claims in the media, in the commercial world, surrounding nasal dilators and nasal breathing. And this is that the nasal cavity produces more nitric oxide than other parts of the respiratory system. If you increase nitric oxide uptake, it helps to, quote unquote, open up the airways. There is also this notion that nasal breathing can improve your general health and wellness. There are also some claims that the additional nitric oxide can help to fight viruses and other infections like COVID. So in terms of the premise, it is indeed true that the nose and the nasal cavity produce more nitric oxide than other areas of the upper respiratory system. This study by Thunberg and colleagues in 2002 showed that the nasal cavity produced 56 parts per billion nitric oxide when compared to the mouth and the trachea, which was 14 and 6 parts per billion respectively. So the nose actually does produce more nitric oxide. And there was a great study here by Cresbo and colleagues in 2010. They used tracer protocol to assess the amount of nitric oxide that was actually absorbed into the lungs. And as you can see here, there are 2 different conditions: an oral breathing condition in which the nitric oxide absorbed was fairly minimal. And during nasal breathing alone, the concentrations of nitric oxide that made it into the lungs were significantly greater. And what they generally found, looking at this panel on the bottom here, was that in the nasal breathing condition, it evoked blood flow redistribution from the caudal and the dorsal lung regions to the less well-perfused cranial and ventral regions. And the authors speculated that this phenomenon, which is only known in primates, may have been an adaptation to bipedalism, but that is just speculation. So in terms of the premise, there's definitely a reasonable premise that, that the nasal cavity does produce more nitric oxide, and that nasal breathing will increase nitric oxide absorption in the lungs. But because of this, there are a lot of baseless claims regarding nasal breathing and exercise performance. This was taken from a personal training website, and they suggest that nasal breathing can increase oxygen uptake by 10 to 20%, which is quite a claim, and also that increasing nitric oxide in the lungs increases the ability of the lungs to absorb oxygen. So let's delve into those claims a little bit more deeply. Is it even feasible to breathe exclusively through the nose during high intensity and maximal exercise? Well, this study by Bennett showed that the nasal breathing contribution to total minute ventilation plateaus at around, well, less than 20 liters per minute. And thereafter, the minute ventilation is increased almost exclusively via oral breathing or oral nasal breathing. And there are other studies showing that the switching point from nasal to oral nasal breathing occurs. Well, there's going to be a range in different people, but it'll be somewhere between 25 and 35 liters per minute. In this study by Derman and colleagues from 2018, they got a group of individuals who had undergone extensive training to breathe exclusively through the nose during exercise. So this was more than 6 months. And they got their subjects to do a graded exercise test to exhaustion during nasal breathing and during oral breathing only. And they found there was actually no statistically significant difference in VO2 max between the two conditions. Actually, there is probably a meaningful difference in that VO2 max in the nasal breathing condition was slightly lower, but the value was not statistically significant. During nasal breathing, however, there was a significantly lower respiratory rate, minute ventilation, and other parameters of gas exchange, including the ventilatory equivalence. So nasal breathing is trainable, but there is little to no evidence of an ergogenic effect in healthy adults. So yes, that there is a plausible premise that breathing exclusively through the nose will increase nitric oxide uptake. It may be beneficial for patients and other clinical populations. There is evidence to show that breathing through the nose can actually increase oxygen saturation in patients. But as I've said, there is little to no evidence that this can improve exercise performance. There is also an increased sensation of air hunger with nasal breathing. So not only might this increase perceptions of breathlessness in healthy adults during exercise, but this suggests that it will be pretty inappropriate for patients, particularly with respiratory disease like asthma and COPD. So given the plausible premise, there is a lot of research now in nasodilators, internal and external nasodilators, with the premise that it can increase the nasal patency, and this is widely used in athletic populations. We went through a period where it was wildly popular in athletes. It was famously worn by Paul Radcliffe here, and more recently Chris Froome, arguably the greatest cyclist in history. And he was paid an awful lot of money to advertise with Turbine, which is an external nasodilator. So they claim that you can see on the top left here that it's clinically proven to increase airflow by 38%. These products were originally developed to aid sleep-related issues, so sleep quality, snoring, sleep apnea, and so forth. And then it was widely used at the Atlanta Olympic Games in 1996, and then it became popular with athletes. So again, if we talk about the premise, this study by Griffin et al. 1997 looked at the total nasal valve area with and without the device. You can see it's a slightly dated study because of some of the terminology that they used here. But nevertheless, with the device, there was a significant increase in nasal valve area when compared to without the device in different subgroups of individuals. Really nice study by Bishop and colleagues in 2016. They used MRI to segment the whole nasal airway into various subregions of interest, and then they assessed the cross-sectional area using the scan. You can see in the table here that when they were using the Breathe Right nasal strip, the volume of the 4 different nasal regions was significantly greater than when using a placebo. So again, the premise is plausible that we can increase nasal patency and we can increase total nasal valve area when using the nasodilators. But once again, when we look at the literature on whether this has an effect on exercise performance, the literature is very unconvincing. So we can say that there's a lot of data actually showing improved perceptions of nasal breathing, and subjective ratings of sleep quality when using these devices. There is little effect on objective markers of sleep issues, including snoring duration and obstructive sleep apnea. But this review that included 19 articles and 168 participants showed that overall, if we look at the conclusions, the external nasodilator strip showed no improvement in VO2 max, heart rate, and RPE outcomes in healthy individuals during exercise. So let's switch pace then and talk about inspiratory muscle training devices, because these have also gained widespread popularity with athletic populations. So the respiratory system is generally considered to be overbuilt for its demands, but this isn't always the case. And certainly in young, healthy athletic populations, there are some circumstances where the respiratory system might limit oxygen uptake and exercise performance. We know that the diaphragm is the primary muscle of inspiration. It distends, it contracts and distends into the thorax during inspiration. And during exercise, the diaphragm's ventilatory functions are prioritized by the phrenic nerve. So we know that the diaphragm has a functional role in posture as well. But during exercise, when the humoral drive to breathe increases, the diaphragm's ventilatory functions are generally prioritized for obvious reasons. And just like any other muscle of the body during high intensity exercise, this muscle can exhibit contractile fatigue. Now, when there's an exercise associated increase in metabolites, this stimulates group 3 and 4 phrenic afferent discharge, which increases sympathetic outflow and increases limb locomotor fatigue. So there's essentially a redistribution of cardiac output towards the respiratory muscles away from the limb locomotor muscles, and this predisposes the limb locomotor muscles to early fatigue and reduced exercise performance, and this is termed the respiratory muscle metaboreflex. In this nice study by Romer and colleagues in 2006, Jerry Dempsey was part of this study. They got their subjects to do a graded exercise test. Before and after the test, they looked at contractile function of the quadriceps muscles using magnetic nerve stimulation. And in the control condition, there was generally a 26-27% reduction in contractile force of the quadriceps. This was just immediately after the graded exercise test. And when they offloaded the work of breathing using a portable assist ventilator, then the reduction or the decline in contractile force of the quadriceps muscles was significantly reduced. So this generally is a really nice study that exemplifies the important role that respiratory muscle work has and potential respiratory muscle fatigue can have on contractile force of the limb locomotor muscles. So with that in mind, there are products now that can claim to increase the contractile strength of the respiratory muscles. The most popular one is Power Breathe. There are claims that it can improve your running stamina, increase the strength of your respiratory muscles, reduce breathlessness. There are lots of other copycat products now, but the original one was Power Breathe. And this is just one of many systematic reviews and meta-analyses I could have chosen, but they generally showed that there are significant improvements in endurance performance following an 8 to 12 week inspiratory muscle training protocol. The improvements are greater in less fit subjects, and the improvements are greater in sports of longer duration, so typically endurance sports. When the subjects do a combined inspiratory and expiratory loading protocol, then the strength gains are superior when doing either one of those things in isolation. And there is some evidence that there is reduced dyspnea at higher workloads following an IMT protocol, but the research in that area is generally less convincing. But this may have a role to play in home-based pulmonary rehabilitation programs for COPD patients and patients with other exercise limitation, but more research is needed in this area. So the penultimate product that I want to talk about is oxygen supplements. And in this case, I'm going to talk about canned oxygen. So this is a spray can equipped with a mask or an inhaler cap. It's intended for commercial, so non-medical use. Usually contains a hyperoxic gas mixture. You can see here they advertise it as containing 95% pure oxygen. It makes me laugh because that's not pure oxygen. But nevertheless, the suggested use of canned oxygen differs among the manufacturers, typically involves several inhalations repeated 8 to 10 times periodically throughout the day when energy is low. and other manufacturers recommend that their products be used immediately preceding physical activity. They make claims like improved reaction time, improved breathing, especially during exposure to heat and pollution, improved sports performance by delaying the onset of fatigue and improving O2 availability. So a lot of exaggerated claims here. Generally, the research is almost non-existent for the mechanism or the ergogenic effects of canned oxygen. And when you go to any one of these websites and you link to the research that they suggest, it's usually tenuously related. So they link to literature on hyperbaric oxygen therapy or prolonged inhalation of medically certified gas mixtures, particularly in clinical populations. But the research is generally quite tenuously related. And just to give you an insight into the more unscrupulous nature of commercial health and wellness, this is a press release that was mocked up by one of the manufacturers of these products to look like a journal article. So it's complete with Excel designed graphs, and I think there were 3 subjects in this analysis and a total of 5 citations. But to the layperson, it's easy for us to look at this as scientists and medics and to know that this probably isn't an authentic journal article. But for the layperson, this gives the product a certain air of legitimacy. So this is when product manufacturers get a little bit more unscrupulous. And finally, I want to finish by talking about breathing interventions, and specifically using this as a case study to talk about the plausible and the implausible claims. Now, there's far too much literature to go into in this short presentation, because breathing interventions comprise diaphragmatic breathing, pursed lips breathing, deep breathing, breath hold, buteyko. And if you plug these various search terms into PubMed, it returns over 15,000 different items, of which there were 70 meta-analyses or systematic reviews. The other problem is that the literature, the published literature, often uses these terms interchangeably, and this makes it very difficult to discern the efficacy of one technique over another. But nevertheless, if we look at the literature as a whole, we can say with some degree of confidence that these breathing techniques are very, very beneficial, particularly for patients with obstructive lung disease like COPD, and breathing exercises make up an integral component of pulmonary rehabilitation. Pursed lips breathing specifically can relieve dyspnea, increase exercise tolerance by reducing respiratory frequency, increase tidal volume, and even reduce CO2 retention and increase arterial oxygen saturation. But as I said, this is a great example of how we can, work with our athletes and our patients and our athlete patients to discern the plausible claims from the implausible. Because again, when we look at the literature as a whole, we can say that some of the very plausible claims are that breathing interventions can increase tidal volume, prolong the duty cycle, reduce air trapping. Pursed lip breathing specifically can evoke a small increase in positive end expiratory pressure, can reduce dyspnea, and deep breathing can also evoke autonomic changes, which can help with relaxation. So this is when we're looking at the more meditative side of these breathing interventions. But some of the less plausible claims are things like improved energy. Whatever energy means in this context, it promotes healing. And, we're getting on very thin ice here. This idea that it can eliminate toxins, personal growth, again, that's very ambiguous. I'm not sure what that means. And some proponents claim that deep breathing can improve the quality of the blood. So we've got to work with our athletes and our patients to make sure that they can discern the plausible claims from the implausible, because the latter just undermine the former. And again, the layperson isn't necessarily going to be able to tell the difference between the plausible and implausible claims. So the main take-home messages then, as I start to wrap up, is that there's a lot of pseudoscience in the commercial world. This is just a very brief whirlwind tour of some of the different products and practices, but I've only just scratched the surface here. Breathing interventions, including nasal breathing, may improve patient symptoms, but not necessarily exercise performance. There's no benefit of nasal dilators, and inspiratory muscle training improves performance, particularly in endurance events. And once again, we have to educate our athletes and our patients to be able to discern science from pseudoscience as best we can. I'd like to say thank you to my co-authors on this paper that is currently in development, particularly Dr. Camilla Alidi from Brunel University. Along with myself, she did a lot of the heavy lifting on this project. And I'd like to mention that I'm sponsored by a fellowship from the Tobacco-Related Disease Research Program. If you'd like to find out more about the work that I do, you can look at my website, nbtiller.com, and I've collated all of my work in physiology and skepticism in one place. You can also link to my column in Skeptical Inquirer magazine. And if you're interested, check out my book, The Skeptic's Guide to Sports Science, which is essentially an extension of some of the subjects that I've touched upon here. And you can find me on Twitter as well at nbtiller. So thank you for your time. I hope you found the talk interesting, and I look forward to taking your questions shortly.
Nick, thank you very much indeed for that fantastic talk. And I have to say, the work you're doing is massively important to provide a perspective and a counterbalance, I think, to a lot of what we read about or we're faced with. And certainly for me is incredibly helpful chatting to athletes who come to me and say, well, hey, what about this, or the canned oxygen that I need to use? And so to have reliable or decent sources of information to direct people to have looked through the science for us is incredibly helpful. I'm sure lots of people online will share that sentiment. So massive thank you to all of the speakers, and we're now going to move to this Q&A session, which will run until 11 o'clock. And so what I want to do is, if you've got any questions, please put them into the Q&A on the Slido system. You can be totally anonymous, so you can write whatever you'd like, provide some feedback to the speakers if you want to in an anonymous fashion. But I'm going to get started, and what I want to do is just start off and take it in order, really. So start with Martin Schwellnus. Thank him again for his talk. But I want to just start off, if I may, with a question about what are the sort of practical things that you can advise people looking after athletes, or even athletes themselves, about some of the warning features which should make you more cautious about expediting a return to sport or return to play? What are the sort of key red flags or triggers that would make you think, hey, let's slow this down?
Yeah, Jim, thanks very much. And thanks once again for the invitation to be part of this. Firstly, let me say that the science around what the question you're asking is very limited. We don't really have studies that clearly show us what are the reliable predictors of a more prolonged return to play. And as a result of that, much of what the consensus group has come up with is expert opinion. Having said that, there are some recent data that that individuals have published. Yourself, you've examined a group of athletes from the UK. We've examined athletes, and there are some recent work from others as well that give us guidelines, certainly on SARS-CoV-2 infection. Essentially, it appears that one of the most reliable predictors, in other words, which athletes are likely to take a longer course, would be related to the symptomatology that they initially present with. And that would, I would say broadly, would be either the types of symptoms, and then what we've recently shown is the total number of symptoms. So broadly speaking, mild symptoms confined to the upper respiratory tract with no, what we would call regional, chest in other words, or systemic symptoms, and no symptoms that may indicate cardiovascular complications. Those would be athletes where the return to play can be expedited to a large extent, and those probably are the best predictors. There is some really early evidence that perhaps if you've been training regularly in the week before you sustain the infection, that you actually return to play quicker, which is perhaps related to the immune system response or robustness of the immune system. There may be other factors like existing comorbidities, which is an important consideration. There's some evidence that maybe females have a more prolonged return to play, but our recent data show that's probably related to other factors like training and not so much being female or male specifically. So those are the kind of things that people can look at. The complicated table I showed gives you an idea as to the factors that we considered and which are more likely to indicate a severe infection with a more prolonged return to play.
Okay, great, thank you. And I should put a shameless plug in for the ISEH. Really, we have developed a questionnaire on there really for COVID use particularly, but has a questionnaire that people can use that identifies some red flag features in the context of COVID that's free to access, and look on the website for that. Just as a follow-up question, what's your viewpoint on the neck check, the sort of historical way in which we characterize or classify severity based on if the symptoms are isolated to just being in the upper part of the respiratory tract or the lower in terms of risk stratification for return to sport? Do you think that still has any merit, or should we just do away with that?
Yeah, I think it falls into the same category of not having any science behind it. But if one perhaps says broadly clinically what I've said about the symptoms and where they're localized, I mean, there is an aspect to that still holds. But we are moving into a period now where we can refine such a fairly simplistic check with good other evidence, and this is what the consensus was all about.
Okay, great, thank you. So we're going to move on to ask some questions to Wayne. Fascinating talk. Thank you very much indeed again, Wayne. So there's some questions about coming in from the Slido about whether hydration and vitamin C might be helpful before flying. Should people be eating chewing gum? Do those things help in terms of providing some sort of protection against infection? What are your viewpoints on those?
My viewpoints, Jim, are probably those very much like your last speaker today, is that there's very little evidence to show that any of that has any effect. I think if one was to go through that list that you mentioned and actually pick one that may have at least a worthy hypothesis that might be of value, it's probably hydration and hydration of mucous membranes while traveling. And there's been a lot written about use of mupirocin or Bactroban in the nasal passages and how that protects us from bugs whilst traveling. And it's probably because there's no science that's been done. My feeling is that that's probably on the basis of a hydration status and maybe the stickiness of that substance that might be helpful in trapping some organisms. But there's no real scientific answer to that question.
Okay. There's a follow-up question here for you, Wayne. You talked about contact or transmission of infection through contact. There's people sometimes play on games on flights like chess, and they'll be involved in sort of sharing chess pieces with each other. I know you've looked after some famous chess athletes, particularly from the Northern Hemisphere. Do you think people should avoid playing board games with each other, or those sorts of contacts that might make them more susceptible to infection on flights?
Well, not unless they are bored, then they should play board games, Jim. But I think, yeah, as long as one cleans whatever it is that you're going to be playing with, you're probably safe.
Okay, don't know who that came through. Okay, so question for Nick. So, Nick, there's some questions here about the place of hyperbaric oxygen. It's gained popularity, certainly in the context of COVID. I've got a number of patients, athletes who are using that as a type of treatment, particularly to help with prolonged or long COVID type symptoms. What's the evidence? Are you aware of work that's been done in the context of sports settings?
Yeah, it's a good question, and it's one that I get asked quite frequently, and I should just as to predicate my response, I haven't done a deep dive on this literature and I've not researched it or written about it. But what I can say is that with hyperbaric oxygen therapy, it's one of those products, if you like, and I mean product in a very general sense, in that it's sold for, it's a service that is generally paid for, and it's kind of similar to the last example I gave in my talk, whereby there is a lot of very plausible science that underpins hyperbaric oxygen therapy, and a lot of implausible claims as well. And we've just got to do the best job that we can to help our athletes, now patients, to be able to discern the difference and draw that very clear line in the sand. Because on the one hand, on one end of the spectrum, you can claim that it's it helps to promote healing, and it helps to not just with the rehabilitation from COVID and long COVID, but some people claim that it can help to prevent COVID. So I think we've got to be very, very clear with what the therapy can and can't do, and be very clear that a lot of the time, particularly in the commercial severe, there only needs to be a tiny nugget of science behind something for that to be extrapolated and misappropriated for the commercial gain. So we've got to be very clear on what it can and can't do with our clients. But generally, the way that it's used in the clinical environment is completely appropriate. It's just in the commercial world where, you know, nowadays you can pay hundreds and hundreds of dollars to go and have oxygen therapy on the premise that it can help to, you know, promote longevity and help make your skin younger and so on and so forth. So again, it's about distinguishing the plausible from the implausible.
Okay, thank you. Questions about the Wim Hof breathing method. I know there's sort of sessions after the break focus particularly on breathing pattern and those related issues. So that might be a question that comes certainly to people like Todd Olin and Julie a bit later on. But certainly, I think a big component of that is cold water exposure and how that might help breathing or recovery from athletic endeavor. I'm sorry to. This is probably, I don't want you to get you into trouble in terms of what you might say about this, but any thoughts on Wim Hof breathing methods or cold water exposure, etc.?
Well, he's a very marketable chap, and it's a great business model. Again, it comes back to this idea that there is a nugget of science in there. So, for example, the cold water exposure stuff is very tenuous. But when you look at the more deep breathing aspects, you know, in terms of affecting autonomic function, stimulating the vagus nerve, can, you know, absolutely does promote relaxation. It can have all kinds of long-term health benefits, and this is probably a large part of the beneficial effect of meditation. You know, mindfulness meditation that's been around for such a long time. There's a lot of evidence showing that it can promote, I hate using the term wellness because it's so vague, but overall wellness and health and relaxation is because meditation generally involves some kind of component of deep breathing. So deep, slow breathing with some kind of short breath hold. Maybe the breath hold is probably not appropriate for most patients because they don't find it comfortable, but these can have all sorts of positive effects on the body. But the cold water immersion stuff, I think, is a little bit gimmicky, and I think that's when we get into excuse the pun, but we get on very thin ice, and that's when we can get into a little bit of trouble.
Okay, thank you. Hopefully that won't be legally challenging, that response. So questions for Martin and Wayne. So you both look after big squads of athletes, or have done, and certainly prepared teams to go to Olympic and Paralympic level competition. What are the sort of important considerations when you look after a squad in terms of optimizing their respiratory health, maybe thinking about screening, maybe thinking about periodic health surveillance? Wayne, you touched upon advice for traveling athletes, but perhaps Martin first. What are the sort of considerations that you have in your mind about making sure that the team is in as good a shape as possible from a respiratory perspective?
Yeah, thanks, Jim. I mean, that's a big question and a good one to ask. I don't think we've got, you know, sort of a totally systematic way of going about it. So what I'm saying now is really sort of my approach, and Wayne would chip in here. It starts off when the first time you see an athlete, you know, normally this is done in preparation for the tournaments. And we had a lot of debate, as you know, in the consensus about screening. And perhaps we don't want to go into all of that, but we have a responsibility at that time to identify high-risk athletes for illness and injury. And in the past, it's always been focused on injury. And we've tried to emphasize the illness component as well. And one of the things is you made a really, really good point, and something I've learned from you during the consensus was the high prevalence of, let's call it lower airway dysfunction. But I think in the past, we've also found a very high prevalence of allergies and allergic disease, including allergic rhinitis. That's why my point about the nose was quite important. And so in the preparation, in that time that you first see an athlete, I think it would be useful to develop an approach to focus on perhaps underlying either not quite well managed or undiagnosed respiratory illness. And that would be my first approach. And maybe, Wayne, I don't know if you want to sort of take it from there. You know, obviously there would be then approaches as you go through the phases of entering the pre-competition phase, competition phase, etc.
Yeah, thanks, Martin. I think what you've mentioned is important. Perhaps my view to this is really putting in a lot of effort to identify the athletes who travel badly. And we've got about 3 or 4 in our team who are notorious travelers. And it is those few athletes who tend to get ill over the time of travel, time and time again. And it is these athletes that you actually need to kind of do every single type of mitigation strategy that you can. And some of them I mentioned during my talk. But these are the guys that you actually hit with, enforcing that they travel with masks, regardless of any mask mandates that are out there. That one actually does go into some of these more radical hygiene states and hygiene practices whilst they're traveling in an attempt to actually mitigate all the risks that you possibly can. These would be also your athletes that you would go into like more advanced strategies for management of jet lag and so on and so forth. But these athletes know who they are. They really are the athletes that time and time again give the traveling physician a real tough time while they're traveling.
Okay, great. Thank you both. There's a question actually just appeared on the Slido about the type of masks that you would use for your teams, Wayne, if they're traveling, and what we would mix, if there's some general advice or recommendations about mask wearing. I mean, especially on long haul flights. I mean, wearing a mask the whole time on a long haul flight is pretty onerous, isn't it? And moisture builds up. And I know we had a lot of considerations about this with Team GB, but what are your viewpoints on the type of mask you should wear and whether you can take it off at times?
James, maybe let me tell you what I do is, generally speaking, I do wear the N95 type of mask while I'm traveling until I actually can't tolerate it anymore, or when I'm going to sleep. And that's when I change it for a normal surgical mask. And I'll also, just keep my head covered with the blanket while I'm sleeping. Whether that makes any difference or not, Lord alone knows. But that's what I do. So when I actually, by having the 2 masks, the heavier and the lighter one, at least I can give myself some respite. It feels like a difference.
Okay, thank you. So questions here for Nick about nasal flow and about the importance of nasal flow. You provided some really nice insights there and some data, and talked a little bit about, I mean, some of the science which tries to promote a nasal or predominant or complete breathing pattern during exercise. What about the advice for people who've got constant nasal congestion, or they might have a deviated nasal septum? Is there science to suggest that should be corrected, or what can be done to try and help those individuals who are actively reporting nasal issues?
Yeah, well, I suppose the first thing to acknowledge here is that most of the benefit of using some kind of internal or external nasodilator is going to be subjective. And there's nothing wrong with that. So if an athlete uses one of these devices and feels some kind of subjective improvement in nasal inspiratory flow, if they feel that it helps them to breathe better, if it helps helps them to breathe a little bit more comfortably, then they should by all means use it. Now, I don't think this is the right forum to get into a discussion about placebo products and the downstream consequences that endorsing placebo products can have. But needless to say, in athletic populations, when they're striving for every 1%, then of course we have to. I think it's only sensible that if an athlete feels that some kind of subjective benefit from using one of these devices, then absolutely, by all means, go for it. The data is pretty clear that it does actually improve nasal inspiratory flow. So in lab-based tests, if you do a nasal inspiratory flow test with and without the device, your peak inspiratory flows are actually higher when you're using the device. the point is that that doesn't actually translate to improved exercise performance, because the switching point from nasal to oral nasal breathing is somewhere between 25 and 35 liters per minute, depending on the study that you look at. So very, very early on in exercise, at very low to moderate exercise intensities, we're going to be achieving most of our minute ventilation via oral breathing. So the nasal breathing contribution to overall minute ventilation is pretty low. But it's probably not going to have a direct effect on exercise performance. But as I've said, if an individual uses it and they feel subjectively that there is that it's more comfortable and that there's an improvement in nasal flow, then they should by all means using it. And I think that's it's interesting, because that the retailers and the manufacturers of these devices know this, and so they're very clear and very careful with the claims that they make and the phraseology of the claim, in that they will say very clearly that it improves nasal inspiratory flow or improves nasal flow, which it does, and then it leaves the consumer to kind of make that extra leap to, well, it must therefore improve exercise performance, and we know that it probably doesn't. But so they sort of imply the claim without overtly stating it, which is a pretty smart play.
Okay, great, thank you. Martin, you got a comment there?
Yeah, can I just add perhaps to that? I do think that for the sports physicians that are listening to this, that one of the things that I've learned in the consensus is the importance of considering the nose and doing a good clinical examination and making a diagnosis of the cause of nasal obstruction. Because what I've also learned, and we sort of intuitively know this, that if you have a constant mucosal swelling aggravating the nasal passage and blocking it, there are other consequences. Firstly, you've got to examine the rest of the respiratory system, perhaps look for sort of general airways disease, but then also to treat that, because the consequence of chronic nasal congestion could increase, again, the risk for infection. So I think just for the sports physicians, besides looking at the effects of relieving nasal congestion on exercise performance, I think there are medical reasons as well to manage that well and diagnosing it correctly.
Great, good stuff. So listen, last few minutes before we break at 11 o'clock, I'm just going to go around each of you, if you don't mind, just to give just a 30-second top line take-home message from your talk today, just that you'd really like listeners to go away with and think about and involve within their practice. So I don't know who wants to go first. Maybe I'll start with Wayne, since he's so close to the screen at the moment. So off you go, Wayne.
Thanks, Jim. Well, I think I would sum up my contribution here is just for your listeners to once again know that the environment that one has when one travels is not without its risks. It is a time of increased risk. It is a time when we are subject to a lot of organisms that can be problematic, and that there are certain mitigation strategies that can work. Above everything, I think, get to know who your problematic athletes are in your group of athletes that you're traveling with, and put some time aside for education of your athlete group, and specifically those athletes who are problematic. Thanks very much for including me in your panel today, Jim. Thank you.
No, thank you. Fantastic. Okay, so Nick, do you want to go next then, please?
Sure. Well, I think my main take-home message will be the bottom line of scientific skepticism, I guess, and that is whether you're an athlete who's looking to enhance sports performance or a patient who's trying to improve their respiratory health, there are an awful lot of products and practices and services that are being thrown at you every single day on all forms of digital and social media. And I think obviously be skeptical, not cynical. There are different words and they have very different meanings. But being skeptical is a positive thing, and just invoke the 3 Ps that I introduced in my talk. Think about, is the product or is the claim plausible? Or first think about the premise. So what is the premise of the claim? Then think, is it plausible based on what we know about how the body works? And then lastly, look at the published data. And if you're not in a position to do that for yourself, then it's perfectly acceptable to defer to one of the experts. Speak to your physician and ask somebody who can look at the published data on your behalf. So always think about the 3 Ps.
Fabulous, thank you very much. So and finally, Martin, please.
Yeah, thanks, Jim. Also, just for the invitation to join. I think my take-home message to all the clinicians and sports physicians who are listening is that I think what we've all learned today and over the last few years is that the respiratory system is incredibly important if you want to protect the health of your athletes. It's definitely the most important organ system from a general health point of view. So we've learned that. So I think focus on that. So if you're going to do something to improve your clinical practice, make it your business to study the system and its diseases and how to prevent them and how to manage them in your athletes.
Perfect. Well, listen, what a fantastic way to finish. Massive thank you again to all of you for speaking. It's been a hugely valuable session. We're going to break now for 20 minutes. So the feed will just pause temporarily. And then Julie Moore, who's our lead respiratory physiotherapist at the Institute, will be coming back to chair the subsequent speakers. And I encourage you to come because we've got some world-class leaders talking on that late morning session, many of whom have stayed up late to join us. And thank you to them. So I will close the session for now and thank you again.